So I've gotten several questions online. I've gotten several submitted here on paper, and I'd invite others to continue. We have plenty of time for Q&A. One of the questions that comes up, and this is online, is about whether there's some sequence of metastatic spread, such as brain and then adrenal and then bone. I'd field this and say that there's definitely not a pattern of cancer, lung cancer, for instance, that typically goes from lung to bone to brain to adrenal at all. For reasons we don't yet understand, but I hope we will in the next decade or so, some cancers have a proclivity to spread to the brain. Some, even of the same type, spread to the liver, the adrenal glands, other parts of the lungs, and we just observe that some cancers, someone's cancer will have a great tendency to spread to the liver, and in others will go to the brain or the bones much more than to the lungs. Some kinds of cancer, one that has historically been called bronchioloalveolar carcinoma and now is differently called lipidic predominant, has a great tendency to spread within. There is definitely not a pattern in terms of a population of cancers that lung cancer invariably spreads first to the bone or the brain and then in some order. It's just very individualized, and at some point I hope we can better predict that pattern. What we do sometimes see is that certain cancers, like small cell lung cancer, has a greater tendency to spread to the brain. Squamous lung cancer does not spread to the brain as commonly as adenocarcinoma. Patients with prostate cancer, it often spreads to the bones before anything else. But we still have a lot to learn about that. I don't know if the panel has anything to add to that.
I would echo your comments, Dr. West. I would say we don't know in terms of the order of spread. Sometimes radiation oncologists who see a lot of patients with bony metastatic disease will anecdotally say that patients with bone-only disease may have, it may be easier for us to make their disease more of a chronic disease. I have some patients who have been treating for 7 to 8 years who keep popping up bone mets every 6 months, 8 months to a year, and I've treated them 10, 12 times, but they're still living and their quality of life is quite reasonable.
But I think it actually does bring up a question. I highlighted brain metastasis as a solitary site, adrenal. Those are clearer. One thing I learned in my training was that it's never solitary in the bone.
That's correct.
And I think the liver is an area that we are not as optimistic is going to be a solitary site. That some sites, a dermal metastasis under the skin is much more concerning than a stray lung nodule in someone. So they're definitely, we have historically painted metastatic disease far too much with one brush. And I think that we will need to refine that better, both in terms of number, but as well as the locations and whether there's 2 different organs involved or one and things like that. So I think we're going to be much more discriminating about those differences in coming years. Eric, you had a comment?
Yeah, I wouldn't say never. I think much more rare.
Yeah.
Because I have a few cases myself with solitary bone that have done very well before immuno and targeted therapy. So I think it happens. The one, and also when you say we're going to learn more about maybe the biology of the tumor, but I also think we're going to have to look maybe at the biology of the host, and maybe that also plays a role as to how these tumors behave.
Yeah.
A little more than what we've done in the past. We've concentrated on the biology of the tumor, but I think there may be some host biology that we need to explore, particularly with this immunotherapy question that's coming in.
Well, that's being integrated much more when we talk about immunotherapy is, whether, and this has to do with both the so-called hot tumors and cold tumors. There's certain tumors that engender a brisk immune response and others that do not seem to be as immunosensitive. They're called cold tumors. And some, it may be their constitution, certain features of their immune system that we can learn more about to try to figure out why their immune systems are heavily activated or very complacent. And so, yeah, there's much more to learn about that. We have several questions about specific areas, and I would invite both Eric from the surgery perspective and Puneeth and Vivek to speak on radiation. Say the issues with regard to adrenal metastases. And we've definitely seen more literature with adrenalectomy surgery. So what would make that more attractive for one approach or another? Maybe Eric, you can start.
Surgery is better. No, I mean, I think
Occasionally.
I think this is another area where minimally invasive surgery has had an impact, is that if the metastasis is small enough and a laparoscopic adrenalectomy is in good hands, is an easy surgery to do, easy surgery to recover from with very little morbidity. So that's an option. There are others where the metastasis may be much larger, where surgery is a more serious undertaking. And I'm not a laparoscopic surgeon, so I can't comment much further on that, but it's definitely an area where this is an overnight stay surgery.
Mm-hmm. With respect to radiation, and I'm sure Vivek will also comment, we do SBRT, or the high dose radiation, for adrenal mets all the time. We in fact can do it for both sides simultaneously. The thing about it is there are some normal structures that we certainly need to be aware of in these areas, depending on whether it's left or right-sided, that we need to take good care about. But in general, we can do it. And there are some groups that will actually not stop a certain type of systemic therapy during the radiation for the adrenal met. For instance, if someone is on a targeted therapy for an EGFR ALK relevant cancer, they won't stop the targeted therapy. Same thing may go for immunotherapy. Of course, we're a lot more careful with the standard chemotherapy. So it's certainly an option. In terms of practice patterns at our institution, if it's a patient that's had multiple mets that have been treated with some form of local therapy over a period of time, it's really about the timing. If it's something that's de novo, it's the first time that it's presented and it's the first location of metastatic disease, we really would like to work with the surgeons to get that maybe resected. But if it's after some period of time with certain amount of systemic therapy, with certain number of lesions, we may go the route of radiation.
I think that's very reasonable. I think that the original data on the isolated or precocious adrenal metastases was at diagnosis. Patient had a lesion in the lung and had a isolated adrenal gland metastases, and those were removed surgically. Back in the day, predating the SBRT techniques, we sometimes did fractionated radiation for those patients that couldn't have surgery. But I think as things have evolved, what we're seeing a little less and less of is that patient population. I think as our imaging has gotten better, we're finding fewer patients that just have a lung lesion and an adrenal lesion, and so I think it becomes more tailored to the multidisciplinary team.
So with regard to other locations, pleural effusions are not uncommon, and Eric, you addressed the concept of pleurectomy. Puneeth, I don't know, is there a way that, did you have any patients with pleural effusions in these trials, or how would radiation address pleural-based disease? Is this a real, not a strength of radiation over surgery? That's my interpretation, is not only is it less likely to remain visible, but it's not that amenable to radiation, and I suspect that most of the patients in these induced oligometastatic trials were not those with stage 4 by pleural effusions or pleural studding.
Right. So I agree. Well, at our institutions, we say we can SBRT any site, except maybe a few very, very sensitive ones. We do, some of these pleural or chest wall based lesions, we do SBRT. We don't use the highest doses we're capable of. We tailor it to the location of the disease. In fact, I will say though that some of these, I think a lot of these oligometastatic disease trials, including some small cell oligometastatic disease trials, they would consider pleural effusion if maybe you were at diagnosis, but at the time of the registration, if the pleural effusion had resolved and there was no obvious site of disease, I think those patients were included on those trials. But in general, I think the presence of a pleural effusion at the time of registration would certainly be one that would disqualify patients from being on these studies, and therefore would probably disqualify for patients from being treated in this kind of approach.
But if you had somebody who presented with stage 4 disease by pleural effusion and that resolved and there was 1 or 2 other areas of disease.
I would not be, I would consider radiating those sites, to be honest with you, with SBRT.
Eric, any other thoughts here?
Well, I mean, I kind of answered that a little earlier, but I think there's one question we don't have an answer to is whether or not, let me backtrack. Surgically, a pleurectomy is very easy to do on the parietal side. On the visceral side, it's a different operation.
Can you explain?
So the parietal side is the side that's on the rib side of the pleural sac. The visceral side is the lung side. And it's a lot easier to remove the rib side of the pleura, the outer part of that sac, with very little morbidity. It's technically a lot easier to achieve a near complete pleurectomy. To do the same on the lung side, it's very hard. It's like trying to peel an orange. Often you get wet because your fingers get into the orange. Well, it's the same thing here. You end up tearing the lung a lot, and it's not as easy to peel out that envelope on the lung side. So there may be a difference as to where the potential role of surgery would be in patients with oligometastatic pleural implants, whether grossly their disease was entirely on the outer side, whether it was on both surfaces or only on the inner surface. You cannot address that radiologically. You can only look inside and see which side of the pleural sac the disease is. Most patients, it's on both surfaces. But there may be a population of patients who have gross, isolated disease on the chest wall side where surgery is easy, low morbidity. Maybe these patients would behave differently. I have no idea.
So Jack, when you study for your boards and you take a test in cancer, there's a question and there's A, B, C, and you pick or bubble in the right answer. But I think in the world of lung cancer that we're in today, there may not ever be a true right answer. There's just an answer for that particular time and place for that snapshot. So there are patients where the thoracic surgeon is doing an operation that if you just look at that snapshot, you think, well, God, that's crazy, okay? But if you actually look at it that for the 6 months before that they refused to do the operation, okay, and this patient has stood the test of time, and now all of a sudden you're like, well, this is a different biology. This is a different patient because I've been able to watch this story unfold over time. I think that's the same thing that Puneeth just mentioned. Well, it's fair to reflexively not treat somebody that has a malignant pleural effusion, but if after time the malignant pleural effusion hasn't run the same story that we would expect, and this person is around and there's 2 isolated spots, I might treat them. So I guess what I'm trying to say is that some of these questions can be answered one way today and 2 months later totally differently, and yet still have diametrically opposed answers, yet both being correct.
Absolutely.
Yeah. A couple of questions came in that I can answer. One is, how do you diagnose lipidic predominant lung cancer? That is based on how it appears under the microscope. It's what's called a histologic diagnosis. So it requires a biopsy, it requires looking under the microscope, and basically it's a pattern recognition. It typically goes with a clinical pattern of kind of wispy, what may be called ground glass opacities in the lungs or an infiltrate. So it's typically limited to the lungs, not, I would not consider this a cancer as being lipidic predominant if there's multiple bone and adrenal metastases in this patient. But the diagnosis is based on how it appears under the microscope. Another question that comes up is about the size of lesions and the value and utility of radiation. And Vivek, you mentioned that smaller lesions are often most amenable to SABR. It would apply as well to SRS in the brain. So can you speak more about that? Is there a cutoff, or how do you frame the concept of the utility and benefit of radiation for smaller, and what constitutes smaller?
Yeah, so I'm not sure that we really understand these things as well as we would like, but intuitively, the smaller the cancer, the more likely we are to control it. So we probably control things that are 2 centimeters better than we control things that are 4 centimeters, better than we control things that are 6 or 8 centimeters. There are some, simple treatment planning issues that as the size of the tumor gets bigger, your ability to deliver these very high ablative doses becomes more limited because you're driving so much dose through some adjacent normal tissues. So somewhere in the neighborhood of above 5 or 6 centimeters, it becomes a little bit more challenging to deliver those ablative doses. Now there are strategies for dealing with that. You can lower the dose and do a few more fractions to get to the same biologic effect. But that's sort of what I was getting at in terms of the size. I don't know if you have other thoughts,
That's exactly right. I mean, what we do is called risk adaptation, if you will. If we're nowhere close to any normal tissues that would be concerned to be radiated, and the lesion is small, we can go as high as we need to. The closer we get to normal tissues and the larger they get, the lesions get, the less high dose we can safely give, which is basically what Dr. Mehta said.
So one of the interesting aspects of the paper or the study out of MD Anderson that I'm not sure made it into much discussion was that the patients who had local ablative therapy, most commonly radiation, sometimes surgery, after a good initial systemic response for 3 months, is that the benefits were very pronounced in the patients with an EGFR mutation or ALK rearrangements, especially. And Puneeth, you've done some work specifically with erlotinib, although not restricted to EGFR mutated patients. Can you speak to any possible synergy or why radiation might be particularly amenable to combination with targeted therapies like EGFR inhibitors?
Yeah, absolutely. So, so one of the prevailing concepts with EGFR mutant cells is that they have had a disruption in their ability to sense DNA damage and for the cell to respond to DNA damage. Under a normal circumstance in a normal cell, when a cell gets damaged, when its DNA gets damaged, there is a programmed events that cause it to die. In a cancer cell, some of these programmed events are awry, especially so in EGFR mutated cells. There's a thought that EGFR mutated cells are generally resistant to certain therapies or become resistant because they have an altered DNA damage response. So when you start using some of these ablative or higher doses of radiation, you were probably able to overcome some of the DNA damage response deficiencies that are present in these cells, and are probably that's why you may see a better tumor control outcome in these populations.
Okay. Other thoughts? All right.
Well, so it's interesting, Jack. So there's that observation in the stereotactic literature. There's some emerging data that some of those EGFR patients, say in head and neck cancer, where they were getting a targeted therapy, we would have thought that that would have panned out, and yet the chemotherapy proves to be better in that population. Do you have an explanation for those observations?
So I think at least the biologists in our group suggest that some of the reasons why things are not overcome as well is because of not just the inherent radiation resistance of those EGFR mutated pathways, but also because of the hypoxic state of a head neck situation, which may be a little bit different from a lung cancer situation, and so that's why there's not as great of a durable response in that setting as there would be for a lung cancer setting.
One of the questions that comes in is about a patient with a long history of BAC, again, this bronchioloalveolar carcinoma. Its name has changed to lipidic predominant, but this is characterized as multiple lesions over time, often a pretty indolent pattern, but multifocal within the lungs. And the question is, basically, should this be considered as a setting where we would want to favor an approach of local ablative therapy? So for this, I would say that I wrote something literally 5 or 6 years ago, I think in 2012, that's on the Gray site, that is a proposed treatment algorithm for multifocal BAC, with a caveat that this is not hard evidence-based. It's just my judgment of how I would approach it, but I think it still holds up as a good judgment, and that is that you do need to think about the question of what is growing at a clinically significant rate. Is it, if it is nothing, then don't worry about treating it at all. I would not be enthusiastic about treating with surgery or radiation 5 or 3 or any number of lesions that are really not changing at a rate of more than a millimeter a year. But if there's 1 or 2, local therapy makes sense. And if there's 4 or 5 or 8, systemic therapy makes sense. So, and if it follows this pattern over time of 1 lesion growing and you radiate or resect that, and then 2 years later another is growing, tackle that. That's my approach, and I think that bronchioloalveolar carcinoma, or BAC, is the concept that I was speaking to in my own presentation about don't categorically exclude multifocality as a reason to do local therapy, even if there's more than 1 lesion visible, but it has to do with what, if anything, is growing at a clinically significant rate at the same time. So, Eric, why don't you speak? I know we've shared many patients who have had resections maybe over time, and we always have these judgments in the tumor board.
Yeah, I mean, I think you have to think about these lipidic growth adenocarcinoma as there's a continuum. And there's an early phase where you don't have to do anything. They're not going to spread. They're not going to cause harm. But there's a phase where that moves up the line. It becomes more invasive. And once the invasive component is more than 5 millimeters, suddenly there's a risk that it may spread. And the correlation, unfortunately, with radiology and histology is not perfect. It's a good guide, but it's not perfect. So I have no problems in watching someone who has a pure, what we call radiology-wise, a ground glass opacity that's not growing, that's under 3 centimeters in size. Because if I was to remove that, the odds are that the odds are very high that the pathologist would see either what's called adenocarcinoma in situ, which means that that's just there, it hasn't gone anywhere else, it's not gone through the membrane, and it's not going to spread and do damage. Or minimally invasive adenocarcinoma, which means that there's less than 5 millimeters under the microscope of invasive component to this tumor. Those also don't spread, they don't do damage. But once it's over 5, and the more you have in size, 7, 9, 12, the higher the size, and going back to the size question, the more likely this particular lesion is likely to spread and cause harm. So that's our approach has been that we watch things, and when things change, or when things become not bigger but denser, so when a pure ground glass opacity on an X-ray becomes denser, that's because there's a higher possibility that there's a bigger invasive component. And ideally, you want to treat them before they go to a stage where it has a potential to spread. And that's the art. And we watch those that change, either they get bigger or they get denser, everything else being equal, patient being otherwise healthy, with a good life expectancy, we will offer local therapy. Now, in offering local therapy for that particular lesion, you have to be cognizant of the fact that they're at risk that these other lesions will also change over time. And your approach to these patients should always be parenchyma sparing treatment. So don't remove too much lung, because at some point in time, if you treat 1, 2, 3, 4, well, suddenly they run out of lung. So that's where it's important to have a discussion. Is this a wedge where I'm not going to take out too much lung? Is it better to treat it with stereotactic radiation? These are strategies. But in general, when things change, everything else being equal, I'm in favor of offering treatment.
Similar thoughts from you guys?
Yes.
Okay.
Yep.
One question that came up, someone had protons and mentioned that they required a lot of planning scans, and they were worried about the risk conferred by all the scans in the planning process and the radiation involved with that. My sense is that that's really quite trivial, both in absolute number and compared to the risk of the cancer in hand, not just something that has a remote possibility of happening. But can you guys speak at all to the risk that you really see if you see a patient talking about risk of all the scans that are required to do a good planning session?
Sure. So this applies not just to protons, but the standard conventional radiation, photons, and as Dr. Mehta alluded to in his talk, the use of image guidance, or these images that we take during or before the treatment to ensure localization and accuracy of our treatment has become a very essential part of our practice pattern. But I tell all my patients, if they ask, that the dose that they're getting from these extra images is minuscule compared to the actual dose they're getting from our curative radiation. And certainly, so the risks of those extra images are far outweighed by the potential benefits.
I think that's completely true, and I think many of our departments have taken further steps to reduce that risk by creating scans that deliver less dose of radiation when they do the scan. And when we're identifying the target just before treatment, doing partial scans if that's a possibility. So it is a minuscule dose, and then we're further reducing that dose. I will say that, just to add a little something, the FDA at the end of this year, early part of next year, will be ruling on a new radiation device that is sort of the counter to what we were just talking about. They plan on injecting PET agents just prior to every radiation treatment and using that PET image to drive the radiation dose, so that there are technologies that will actually increase the amount of radiation imaging as we deliver that dose, in the hopes that because we're getting more accurate targeting, we're actually reducing surrounding tissues. So there's always going to be a little bit of this, but again, in comparison to the therapeutic dose, a minuscule amount.
Okay, great. One other question that comes in, I think I can field, is about tumor mutational burden. And this is a different issue. Tumor mutational burden is basically the number of mutations that are detected in the molecular analysis of a cancer. So typically the cancers that have a driver mutation are kind of a ninja that doesn't need to have a large number of mutations to have much effect because it's so effective, but it's in stealth mode, versus a mob scene, which is what other cancers tend to be, which is not that coordinated or stealthy, but they just have the sheer volume to attack. And so some mutations or some cancers are driven by predominantly by one very effective mutation like EGFR or ALK. Others, like small cell lung cancer, it's not likely to be taken down by by hitting one mutation, because it's actually driven by a dozen or hundreds even of mutations all contributing a bit. And that's part of why our pill-based therapies that are great at attacking a driver mutation don't work for many other kinds of cancers. So, but tumor mutational burden has been associated with efficacy of immune therapies. It is not a perfect correlation, but in general, the cancers that have more mutations are more likely to be detected and effectively neutralized, attacked by the immune system. And it's almost like lottery scratch tickets. I mean, you may not have a good chance of winning with any one, but if you have a big pile of them, you have a better chance of winning than if you have just one. And so in general, the cancers that have a large mutation burden have generally had better efficacy with immunotherapies. But it's not, at this point in November of 2018, a standard of care test. And right now, the marker for PD-L1, a protein on cancer cells that is kind of an ID tag that can be forged by their cancer cells to elude the immune system, that protein is the standard of care for predicting which patients will benefit more. It's not really that they have nothing to do with each other. Tumor mutation burden and PD-L1 are two totally unrelated markers. They each seem to have a predictive ability, but at this time, PD-L1 is a standard of care to test for. Tumor mutational burden is something being studied and may emerge as something we look at, but isn't replacing anything and is not a standard of care. I'd like to turn to the question of immunotherapies. We've all mentioned that immunotherapies are changing things, that they are at least conferring more patients to good responses and kind of teeing them up for potential local ablative therapies. But how much or how little do you think that there could be some good interplay between a local therapy, and if so, does that mean that this is more likely to be with radiation and the so-called abscopal effect, the benefit of the immune system outside of the treated area, and does surgery have any such interaction at all potentially? Maybe we could start with the radiation approach, if one of you can speak.
Well, I think that abscopal effect has been sort of documented and seen in certain cancers, not in all cancers. I think that there is emerging data of immuno-oncology agents and radiation showing that there's some synergy that we didn't previously understand, and we're working on the timing of when to give the radiation relative to those immuno-oncology agents. So there's still a lot to be learned, Jack, but I think that that's a potentially exciting area. That's kind of what I would say at this point.
Yeah, no, I agree. Certainly we feel that for renal cell carcinoma, for melanoma, for some of the what we would consider more immunogenic tumors, that there is some synergy, meaning we can irradiate one lesion and then 3 other lesions that have not been irradiated but do get exposed to a systemic treatment. There's actually a benefit because of another lesion being irradiated. So I think in those cancers, the data is more convincing. I'm not 100% sold on non-small cell lung cancer. We still have to generate more data. But I do know that there are trials being developed right now where even in oligometastatic non-small cell lung cancer patients, or even beyond oligometastatic, patients with widely metastatic disease, there are plans to radiate a few lesions, not all, but a few, along with immunotherapy to see if that synergizes the immune system to act on the lesions that have not been irradiated. So that question hopefully will be answered in a more systematic approach through these clinical trials.
So before we get to Eric, would you take a stab at a general question? Do you think that radiation oncology radiation treatment stimulates the immune system or suppresses the immune system?
Stimulates. That's
Okay.
there's some data from Stanford that suggests that there may be both, a mixture of those two, but I think the overall benefit is probably one of a support of the immune system to act further.
Mm-hmm.
And comments, Eric, would you say that a minimally invasive approach, you were talking about the minimal disruption to systemic therapy, so I would say that one thing about systemic therapies now is that more of these are less toxic. You don't need to miss a beat with starting them back on targeted therapies or immune therapies don't require, a huge amount of fortitude oftentimes. And so, but having minimally invasive surgery approaches, less recovery time can only help. But so thoughts on the interaction with the immune system?
So as far as the timing, the few patients that I've done on immunotherapy, I have not stopped it, and I've just continued right away. Same with EGFR TKIs. So as far as timing, as long as the patient can take it, it's not an issue. It's not like with cytotoxics where you need the marrow to recover, you need everything else to recover. There may be some patients where there's a risk of pneumonitis, where that could hurt you perioperatively, but we'll deal with that. As far as immunology, the immune system and surgery, you are correct that there is some data to suggest that minimally invasive approach, there is less diminution of the immune status of the patient perioperatively than there was with open surgery. That's comparing to conventional open surgery. I'm not sure that today's open surgery is as immunomodulating as it was. One of the issues that worries me a little, though, is the timing of surgery with immunotherapy. There are some theories out there that for those drugs to work, the lymphatics and the lymph nodes have to be intact and aware. And if you go in surgery first and you clean all that out and you come at it afterwards with immunotherapy, you potentially could not see the same effect as if you went with immunotherapy first and surgery second. That's one of the things that's going on in the surgery literature, but it's all theory right now. There's no data. And that, to me, is going to be one of those areas that's going to be the most fascinating to study, is how much of an impact does radiation therapy have on the potential of these drugs, how much surgery does as well. And we're in the unknown right now. A lot of theories.
So, Eric, just to follow that up, there's sort of this opinion that we sometimes hear from patients that surgery triggers metastases, and there's actually some literature suggesting that surgery triggers metastases. Do you have any comments on that?
That literature is mainly in the Reader's Digest. There's very little evidence of that. I'm sure there is a patient here and there. A lot of that comes from grandma who they opened up and they closed her up, and 3 months later, the cancer was all over. Well, this is in a time where we didn't have imaging like we have today. We didn't have PET scan like we have today, where we would have identified grandma as having non-surgical disease from the get-go and never opened her up. I'm sure there's a case here and there, but overall, the answer is no. There's no evidence of that.
So, one interesting question before we get to our last, and that is, one issue with local ablative therapies someone raised online is that, well, you wouldn't qualify necessarily for clinical trials because you need to have some measurable disease. And I would say, yes, that's probably true. Many trials do require measurable disease, but the fact of having no visible disease for a long time isn't the worst problem. But yes, it's a realistic issue. But the last question I'd like to ask is just the general one of, where do you see local ablative therapy for stage 4 right now in terms of being a standard of care? And I'll throw out my answers that I think of it like it is, I would call it a reasonable standard, not the standard, but I would emphasize that it really needs to be for a selected population, that it's a tool and it's like an EGFR inhibitor that, yes, it is potentially very, very helpful for patients who are well selected. And that's not a coincidence that we have these trials that have enrolled 29 or 50 or a few dozen patients over years. This isn't something where there's a deluge of patients out there, because I think if we were to study ALK inhibitors unselected, we would not see good results. But if you pick the right patients for it, you can get very good results. And right now, there's still some judgment involved. But I would consider it, I just think the key is it is a very appropriate thing to do for well-selected patients. But I wouldn't be too heavy-handed in calling it something that most patients should be getting at this point, particularly if they have more than 1 or 2 or 3 lesions. But maybe we can work our way down, Vivek. if you
Yeah,
can,
so I think that's a really challenging question because there's an intellectual answer, which I think is kind of what you gave, that there is a select group of patients that would benefit from it. And then there's the patients that you see in your clinic where you're trying to figure out what the right thing to do for them is. And I think it's an exciting time to consider local therapies in those patients. If you had a crystal ball and you knew who was going to benefit, you would obviously only treat those patients. At the same time, if you had that crystal ball, you would only give the drugs to the patients that needed it. Sometimes we look at the healthier people that are in front of us and give them the benefit of the doubt and want to treat them more aggressively. Other times we wait for people to stand the test of time and then try to give them the benefit of the doubt. So I think we're trying to do our best job at judging these patients in an inexact science with incomplete information.
I agree. I think what Dr. West and Dr. Mehta are saying are that we try to be both intellectual and pragmatic at the same time. I will tell you just honestly, our approach at our institution is if we have a trial open for that population of patients, we try to put the patient on the study, especially these oligometastatic patients, because we don't have a definitive answer, certainly not based on these very small studies that we described today. But the more relevant question is if you don't have a trial open at the place that you go get treated, I think that it's a very reasonable approach that if you have gone through multiple cycles of systemic therapy and you have now you're on a second or third line and you have one lesion that's progressing, why not be pragmatic and stay on that systemic therapy and treat that one lesion with a local ablative therapy? I think it's absolutely reasonable. I think the question becomes less reasonable when you're trying to bring it more towards a first line approach, because quite honestly, as I mentioned too in my talk, I don't know if immunotherapy is going to make the benefit of local therapy greater or less or the same. And so if I'm uncertain about that, then I can't be so gung-ho about bringing it into a first line setting. I think for me and our group, when it's progression and people are starting to fail certain classes of drugs and moving on to the subsequent classes or trying not to, we're much more pragmatic. I think probably in an earlier line approach, first line approach, or when the patients are getting started, we're probably a little more dogmatic.
And Eric, last word?
I agree with everything that has been said. Everything we do is weighing risks and benefits, and we can judge the risks right now, but the benefits we have no idea. So the way I look at it is if a patient in such a scenario, and by the way, the presentation you gave I think explains very well our lines of thought is at diagnosis, down the road, oligo progression, all these things play into our decision making. But I mean, what I tell the patient is, listen, if it was like popping a zit and I get you home the next day, I'll do it. I don't know what the benefit is, but the risk is very, very low. On the other side, if the risks are high and I have no idea what the benefit is or are, then I probably should back off a little. And that's the game that's the art right now, until we have science to back it up.
Well, I think that's a great point. I think, and that's really a large part of my view, is that concurrently we have emerging data, if not perfect data, but emerging data that the benefits are potentially great, even if it doesn't have to be curative, but it has a good chance of being beneficial and a pretty low risk of real harm, especially as the burden in terms of morbidity with either radiation or newer surgical techniques gets lower. The burden of proof doesn't need to be as high. So it doesn't mean we should be cavalier about it and we shouldn't just do it for 12 lesions for everybody, but we, I think, should modulate how intensive we need to be and how restrictive we need to be based on the challenge of the treatments in front of us. So I've gotten some other comments that came in, just thanking our panelists, which I really want to do as well. Thank you guys so much for taking the time and putting together great presentations that are so accessible to people here and the broader people, community of people out there, not just doc speak. And I want to thank Grace and everyone here who's made today possible.